Hey, Dr. Bob here from Cordova today. It's a Sunday, so I try not to do any work, but I don't count talking to you guys as work. And there's been some requests for me to talk about the COVID vaccine because I've got a lot of people that follow me, from the paramedics I used to train to my own personal patients and family members. And of course, everybody's freaking out. And I'm going to take the opportunity to do more than just talk about the COVID vaccine. I'm going to spend a little time on COVID in dire hopes that this is the last time I talk about COVID, because really what I want to talk about is health, wellness, and how to prevent being a person that has to worry about getting COVID or other diseases for that matter. And COVID derailed me from that project last year when it kind of took up all my bandwidth, as sort of an obligation as a doctor. But I'm sort of COVID burnout, and I really don't want to invest the rest of my life reading about it, though I do spend a lot of time reading some of the studies and a lot of the opinions, and certainly, of course, I've formulated my own. I'm a little worried because I think that powers that control the flow of information tend to take stuff down if it doesn't fit the model that they're looking for, and I'm a little worried this one might not hang around too long, so we'll see what happens. I'll start out right now. I'm not an anti-vaccinator, but I'm not big on viral vaccinations for healthy people. Okay, before we go into all this, as you guys recall, I caught COVID. Let me see, I'll look at my watch here. It's the 20th. My first day of symptoms were about the 1st of November. My quarantine was over the 12th. I was largely asymptomatic by then. I think I brought you guys the video on symptom day 11 or 10. I was over the kind of fever, feeling crummy by that time. I'll be honest, for a couple days I could still tell my physiology had been impacted. And here's what I mean by that. On day 13 and 14, I worked out, and I could tell after my sets that I was a little bit lighter headed and a little less, on top of things than normal. I mean, I've been training for years and years and years, and there was something different. And I'll be honest also, I kind of had that little low-grade headache. Was less than during the actual infection, but it kind of hung around for a little bit. In the mornings, primarily, I'd wake up with a slight headache. When I finally did get home, I checked my oxygen sats. They were always 97 and 98%, so I never developed any lower respiratory disease. And interestingly, I did get my labs drawn 3 weeks to the day after my first day of symptoms. And most importantly, and I don't know if you guys will be able to see this, sorry for the lack of professional quality, but this is my antibody response. So what we can see is that my IgM, or early antibodies, were all positive for both spike proteins, the proteins that attach, and my IgG, or late antibodies, were positive and probably climbing at this point. So, and then they test for 2 other proteins in this vibrant antibody test. So I tested positive to everything. I have immunity right now. Makes the vaccine decision really easy for me. No need. I will probably recheck this every 3 months. So we may have better information on me about how long the antibody response lasts to actual natural infection and natural immunity than anything I can get from the literature, which right now they're saying 90 days. The one nice thing about catching the virus, if you fare well, is I have a thing that says that I've caught and recovered, which for 90 days, basically there's no reason to test me. People can shed the messenger RNA without intact viral particles for up to 89 days, so they don't bother testing. Okay, so that's interesting, number one. Number two, I did my routine labs, and my routine labs included a couple of tests that are sort of tests that you check on people who are sick when they're in the ER. One is Ferritin, which is an iron storage molecule, and it gets really high in people with COVID. I was seeing levels of 1,000 to 1,500, and mine was in the normal range, although the highest it had ever tested actually at low 200s. And then high sensitivity CRP, which I was seeing readings of like 20 and 30 on patients that were sick. And 3 weeks after this infection, mine was at the highest but upper limit of my normal, 0.6, with the upper limit of normal being 1. Now, one of the reasons why I always maintain a very low high sensitivity CRP, that's a test that's associated with blood vessel inflammation. I probably have some pretty good genetics there, but I also lead a very anti-inflammatory lifestyle. Diet, fish oil, and exercise are probably 3 things that can help mitigate elevations in high sensitivity CRP, which drives cardiovascular disease. Okay, so where am I at today? Well, what's it been? So now we're at about 50 days since infection. Nothing. If there's any lingering effect on me, I am totally unaware. So my plan going forward is, with my quarterly labs, I'll check my vibrant antibody test. I will not take the vaccine. I do not see any. I haven't been able to find a vaccine study that says they've studied it in people who have been infected, and yet I see some of these pundits out there saying that if you've had the infection, you ought to take the vaccine. I have no idea what kind of systemic inflammatory response I might have if I take the vaccine, and what's the point? I mean, the goal is to develop the vaccine is to one of the spike proteins. Let's talk about what that vaccine is. Okay, so it's a small fat envelope, a thing called a lysosome with messenger RNA inside. That's pretty much all it is. That fat envelope will bind to cells, and the messenger mRNA will get inside your cell where it can get to the ribosomes, which is where protein synthesis occurs, and your cells will start to produce the protein to one of the spike proteins, and your body will start to react to that because it's a foreign protein, and you'll develop antibodies to one of the proteins, not all 4 like me. Now, I'm told that messenger RNA is pretty short-lived, so this is not something that's going to change your DNA. At least I don't believe so, and I don't think there's any microchips in there. In fact, I think they're drawing it up from vials. Here in Cordova, the nursing home patients all received it, 10 of them, I believe, and a number of the staff did. And I was working and I did not get called in. We didn't have any anaphylaxis, though there have been some very few cases of anaphylaxis. But I'm going to take a look and just sort of review this one blog that I read that's, it's a Christian blog, I'll be honest, but it's very well written and mirrors a lot of my concerns in the first half, and then they sort of go off the deep end in the second half. The blog's entitled, "What's the Real Motivation for Attempting to Vaccinate Millions of Healthy People?" I guess I'm going to go ahead and break this down as, look, I've been a very high quality disease model doctor practicing within the constraints of the disease model of medicine for many, many years. I've never spoken to a lawyer. I've seen 60,000 patients. I graduated pretty high in medical school. I'm pretty competent, and I think I can digest information and come up with reasonable opinions. And I'll tell you what, it's complex to dissect motivation in the disease model because it is a profit-driven model, and you have to follow the money. And let's face it, the drug companies have a lot of money at stake here, and 300 million vaccinations is going to pay a lot. This is an actual was previously vice president of Pfizer, senior research position guy, who basically points out that there's no need to vaccinate healthy people to create herd immunity. He does point out about 30 to 40% of the population having T-cell immunity prior to the arrival of the virus. I believe this is true. I've read some studies. I read a family study early when this was going on. 2 family members caught the virus, got sick, produced antibodies. The other 5 who were clearly exposed in the household never did. And they actually did some advanced type studies and showed that they had T-cell immunity, natural killer cells that were so well poised to kill coronavirus that it worked on this. Let's remember, there's lots of coronavirus out there, okay? So some people have had a lot of infections. I've seen exposures in my personal life, my pilot this summer, and somebody that was staying in the efficiency suite with him for a week who never got sick. I know of another guy who had multiple exposures and kept testing negative even after sitting in a car for 15 hours with a guy who ended up the next morning having to go to the hospital. And anecdotal evidence suggests that there's cellular immunity, that not everybody catches it. I've read some opinions about like the cruise ship that was anchored up, only 20% of the people got that, and they had no way to quarantine, and pretty much everybody got exposed. And you know, a lot of virologists would also tell you that in the early going, everybody in New York City got exposed, or nearly everybody, because of the demographics of how New York is, and elevators and mass transit, and this was out of control before we got a handle on it. So there's certainly some people that will never get this virus, and they're going to receive a vaccination for no reason, but it'd be very difficult to sort out who that is. The other thing is, I'm sure the actual infection rates are 2 to 3 times higher. There's lots of people who don't get tested when they have mild symptoms. Hopefully they're reasonable and they stay away from other people in case it is COVID. Some of them probably are, and they have not established that they've caught the virus, so they're not going into the positive case number, which makes it look like it's got a higher mortality than it really does. Those people who have caught the virus but didn't get tested probably also won't benefit much from a vaccine. He points out, so there's some natural immunity already in the herd. There's some people in the herd who have caught it and not been diagnosed, and then there's the people in the herd who we know have caught it, like myself. So why are we going to give 300 million doses? Well, again, follow the money. I worry about that. Not an anti-vaccinator, but pick and choose wisely based on your own demographics. You know, this guy also points out that, you know, a lot of the information that goes against sort of what I would say is the pharmaceutical government take on this is being massively suppressed by media and big tech, and I think that's undeniable, and he cites several examples. And one that I personally think is unconscionable is the fact that the hydroxychloroquine information got suppressed or refuted without adequate testing. So hydroxychloroquine, zinc, Zithromax, many doctors have said clearly this is working, but nobody ever ran a quality double-blind clinical controlled trial that I can find anywhere, and I've looked hard, with early use, okay? So here's the deal. The only test they did that showed harm was they started giving it to people in the ICU. Now here's the problem with that. The expected result would be that you would see increased mortality. And here's why. The proposed mechanism of this issue is hydroxychloroquine probably stops viral entry into the cell and maybe helps to prevent replication. If you're already in the ICU dying, that horse is out of the barn. Both hydroxychloroquine and Zithromax do a thing called lengthen your QT interval, okay? Now, what that means is it makes it easier for you to have arrhythmias. Now, as an ER doctor, I've taken care of thousands of critically ill patients, and what you eventually usually die of is ventricular fibrillation, which is a fatal arrhythmia. So if I have people circling the drain, their metabolic milieu is deteriorating, their kidneys aren't working, electrolytes are building up in abnormal fashion that also contribute to arrhythmia, and I give them 2 drugs, hydroxychloroquine and Zithromax, or even one, that and I said lengthen, shortens your QT interval, it makes you more likely to have an arrhythmia, you see a slight harm in that study. And that's the only study I can find that's double-blinded. Now, why are there no double-blinded studies? Well, because we'd have to rely on our government and our CDC to do those, okay? Because there's no drug company that stands to benefit financially from an expensive giant study that would be required to prove whether it works or not. Ivermectin's another example that falls into this same category. Definitely works, I think. Both of these drugs we would call repurposed drugs, meaning they're used safely for other conditions, and they appear to work, but nobody studied them to prove they work as they would need to be used early. And I would use them early, and I did use these on several of my patients, older patients with hypertension or other comorbidities. I had to use them off-label, and I had to fight with pharmacies to get them prescribed. So another unconscionable thing. Anyways, we need the government to run the studies because if we can find a cheap, repurposable drug that lowers mortality, we should be all over that. They never did it, okay? Why? Follow the money. The largest lobby on planet Earth, I believe, is the United States pharmaceutical industry. I'm sure they have a lot of power in who gets appointed to the CDC, the FDA, and all of that through typical political ongoings. And here we are with no studies to prove or disprove that early use is effective. All right, so stuff gets suppressed. All right, so here we go. Novel vaccination that we intend to use on the entire population for a disease that has a 99.6% survival rate, and that's if our numbers are correct in terms of total infection, which they're not. So the survival rate's higher than that probably. It's a little, hey look, it's a real deal. It made me sick, and I don't get sick, okay? It'll kill old people. It'll kill people with comorbidities. In those populations, it is more dangerous than the flu. In the young and healthy, it's probably no more dangerous or a little less dangerous than the flu statistically from what I can gather. So, it's rushed. I agree. It's probably safe, guys, okay? But we don't know. So the article then goes on to talk about what are the motivations, and they're worried it's going to change your DNA. I don't think that's an issue, okay? I'm not a virologist, but I don't think this is designed to get inside your DNA. It's just going to print proteins and then kind of slowly degrade, and I think that's probably true. Second thing, population control. According to this article, I didn't vet it. If you actually read the COVID-19 Acts mRNA vaccine, it is not known whether it could have an impact on fertility. Okay, big deal. I don't recommend young, healthy people getting it anyways, with the exception being if you're a frontline worker, you're going to have to wrestle with that decision, which we'll talk about in a minute. And then the branding. The microchip, the digital code. I am seriously not going there yet. I'm not sure that they're not eventually going to try to take us there in this current climate and world in which we live, but I don't think it's happening with this vaccine. Okay, so I'm through with that. I'm going to get to the proximate question. What about the vaccine? Here's the easy group. You're 80 years old, take the vaccine. The disease probably does have a mortality risk approaching 25%, and I am pretty sure the vaccine is not going to come anywhere near that. You're 20, healthy, and can control your bubble so that you do not expose 80-year-olds or other high-risk people, you might want to just keep your head down and try to not get the vaccine. But you know what? You're not even going to have an option for it for months. And if it works, with the amount of herd immunity through natural infection, because it's pretty contagious, and the fact that all the old people are getting vaccinated, or most of them, and a lot of the healthcare workers and other frontline workers are getting vaccinated, and then a lot of essential workers are getting vaccinated, the herd immunity may occur, and this may go away prior to you ever having to get either the infection or the vaccine. So do I think it's reasonable for a young, healthy person to just try to keep their head down and get away without either? Absolutely. You're fairly young, you're healthy, but every time you get a sniffle, it's impacting your livelihood because you can't work. Very reasonable to consider the vaccine. It's probably fairly safe. You're young enough and healthy enough that you probably don't need to protect yourself from this virus, but you can't control your bubble. The paramedics, for example. Now, you can try to keep your head down and be really conscientious and hope, just like a young person, that the herd gets immune and you escape getting either. Does that put you in the position where you might expose another person? Sure. Could you kill somebody? Yeah. Is the vaccine sketchy enough that I think you're a jerk if you don't get it? Yeah, I mean, it is sketchy enough. I don't think you're a jerk. I understand wanting to protect your own health, maybe not wanting to be in the first round, maybe wanting to see what it looks like in 3 months after the first 100 million people have got it. There's a lot of reasonable approaches. So there you have it. That's my thoughts on whether or not to get the vaccine. I would have taken the vaccine had I not got the infection. I doubt the vaccine's going to harm me. But now that I've got proven immunity, I'm going to follow that, and I'm not getting the vaccine until I see evidence that the vaccine has been studied in people who have got antibody response to natural infection, and that there's not an adverse outcome in that group. Okay, so I'm done. Other than I want to plant the seed. Listen, I'm hoping I never talk about COVID again. Not likely, but I'm going to try. I am going to get started on my walk with the proactive healthcare methodology that I follow through my Synagenics practice. Here's what I've observed as a disease model doctor for many years. We're great at treating disease, but most of us is in this model where we're all waiting around to have the first symptom of end organ damage from preventable or reversible diseases that do not require pharmaceutical medical treatment. Okay, so here's what I'm talking about. Things like heart attack and stroke, which get about 60% of us. There are a lot of testing capabilities now that are relatively inexpensive, particularly if you pay cash for them, that can help identify the evidence of disease of the blood vessels well before there will be symptoms. Examples would be carotid ultrasound and coronary artery calcium scoring and coronary CT angiograms. There's a lot of blood work testing that, when looked at in greater depth, can identify tendencies towards type 2 diabetes. They can identify tendencies towards systemic inflammation. Obviously, the cholesterol panel, which is something that's followed pretty well in the patient population in the disease model, but that's because they have a drug or drugs, the statins, that they reflexively throw people on if they have a bad cholesterol panel. So I'm going to tell you just briefly about my little walk over this 8-year period that I've been a Cenegenics physician. And then if you want to hear about detail, chronic disease, why we develop it, nutrition, how to prevent it, exercise, how does that work? Why does it work? How simple it is to develop an efficient exercise program that will prevent chronic disease. Why hormone optimization makes sense and is safe and effective in most of the population around andropause and menopause, the times when your male and female hormones are declining. And why supplementation, despite the refutation of the disease model, is sensible and works. I am going to start my lecture series and cover all of these. I'll put them in a special file on YouTube so you can follow them. Okay, so here's been my walk. So 8 years ago, I was starting to get overweight. I was following a healthy disease model, dietary program, low fat, high carb, lots of whole grains. I was starting to feel poorly, and I found Cenegenics, and I received enlightenment. I massively transformed my health since then. But more importantly, I learned to survey my health to make sure I wasn't a ticking time bomb just waiting for the first sign of end organ damage like chest pain or a stroke. I remember seeing a 47-year-old when I was 47 who had a similar body habitus, no real risk factors, had a heart attack. And I thought, how do I know that's not me? And the answer was, I don't. And that was part of my motivation for finding Cenegenics by age 48. I'm now 56 years old and quite confident that I'm very, very healthy because I've done the work. Okay, so initially my labs were imperfect. My cholesterol panel was much worse than I maintain it now, but I have a genetically bad cholesterol panel, which is one of my larger chinks in the armor. I've wrestled with whether I should be on a statin or not because according to the American Heart Association primary prevention guidelines, the answer is yes, I've never taken a statin. I also wrestle with aspirin therapy because if you have evidence of plaques, you should probably be on an aspirin. So going along now, 8 years, hormone optimized, exercising, changed my diet, feel great, life's good, still don't know about those two questions. Have looked at my carotids annually for 8 years. I have no evidence of blockages and pretty thin walls. Not much in the way of family history of coronary artery disease, but my genome tells me I should be obese, and I have 9 genes that predispose me to type 2 diabetes. And my dad, when he got old and fat, and his dad, when he got old and fat, ended up on insulin. I don't have any evidence of type 2 diabetes. I have no evidence of insulin resistance. My fasting blood sugars are very low, 60s and 70s usually. My fasting insulin levels are either undetectable or less than 5. And my hemoglobin A1C runs really low, 4.8 to 5.0. So I'm beating diabetes through lifestyle despite genetics. But what about the blood vessels? Well, it turns out some people have blockages in their heart with perfect looking carotids. So I went ahead and did the coronary artery calcium score, and I did a coronary artery angiogram in Las Vegas while I was there seeing patients a week ago. Cost me basically $585 for both tests. And I now know that I have perfectly clean coronary arteries, which actually downclassifies my risk of having a heart attack or stroke in the next 10 years from about 3% to 2%. But had my calcium score been high and had I had shown small plaques, I would have been up-classified. I probably would have started a statin, and I probably would have started aspirin therapy. This is healthcare, my friends. We have a disease care model in this country. We wait till you have symptoms of disease, and then we throw medicines at it from the pharmaceutical industry. If you want to learn about healthcare, how to do it, what to follow, what the labs mean, a really in-depth, easy to understand, because I've always been complimented on that, dialogue through this venue, start following my YouTube. Sorry this went so long. I answered your questions, hopefully. Good luck to everybody. Merry Christmas. I'll try not to be too slow about getting this data out. Have a great one. Thanks.